Oh shoot, I forgot to add the drug. Okay, well, welcome to Road to 250. Today I'm going to do bug, it's going to be Listeria, drugs are going to be opioids, and then the concept's going to be epithelial cells. So to start off with, Listeria. All right, so give me an idea of what Listeria is. What are our bug properties for Listeria? What gram positive, gram negative?
The gram positive rod.
Yep, gram positive. And yep, its shape is, it's a rod shape. And is it motile or non-motile? It is motile, which is actually quite characteristic of Listeria itself specifically. And is this a catalase positive or a catalase or not catalase bug? So this one's catalase positive, and it's also oxidase negative. So, and then for hemolysin, is it? Does anybody know whether it's alpha, beta, or gamma hemolysin? Hemolytic, beta hemolytic. So Listeria is beta hemolytic, and if we remember, in beta hemolytic, essentially when it's plated on blood agar, there's an area of hemolysis, so destruction of red blood cells. So kind of gives you also an idea about pathogenicity. So, oops, it went the opposite way. But yep, so like it says, gram positive, it's facultative intracellular rod, meaning it chooses to where the bug chooses to live. It can be intracellular. And it is acquired or transmitted through unpasteurized dairy products, which is commonly seen, and cold deli meats. And hence why it also grows well in refrigerated temperatures between 4 and 10 degrees Celsius. It's also transmitted through transplacental or bivaginal transmission, and that'll make sense for some of the causes that Listeria can produce. And okay, so I was going to ask you guys this, but when I mentioned that Listeria is motile, it's quite characteristic of Listeria because when we see Listeria under microscopy, we see these things called rocket tails, if you will, or more characteristic is like tumbling motility, which is seen in this picture here. And I guess from what I read, it is if Listeria is inside the cell, it's going to use its actin polymerization to have intracellular movement. But it also has flagella, which allows it to move outside the cell. So it kind of has that characteristics of it being motile. And so what does Listeria cause, or how does it manifest within us? So it can cause amnionitis, septicemia, spontaneous abortion in pregnant women, and it causes granulomatosis, infectious, and neonatal meningitis, and immunocompromised patients as well, and then self-limiting gastroenteritis. So, so as we know, newborns, the neonate meningitis is one of the 3 bugs, is Listeria. Does anybody know the other 2 that cause meningitis in newborn babies? You can remember it as baby bell or baby gel, and that's group B strep. E for E. coli, and then L is for Listeria. So those are the three top bugs that cause meningitis in neonate babies. And then also, if you were to look at the trend of what bugs cause meningitis throughout the age groups, it's also, like it says, most common in immunocompromised patients or elderly. Listeria will come back as one of the bugs to rule out. And then, like it says here, the treatment of choice for Listeria is going to be ampicillin. So, yeah. Anybody have any questions or anything that they'd like to add for Listeria? All right. Then I'll move on to our next topic, which is drugs. And that's going to be opioids. So our opioids are going to be known as morphine, oxycodone, fentanyl, codeine, loperamide, methadone, meperidine, dextromethorphan, diphenoxylate, and pentazocin. And these drugs act as agonists at opioid receptors. And okay, sorry, that's a little off. But so our opioid receptors are going to be mu, the delta, and kappa. And mu receptors are going to be the receptor responsible for the opioids that are going to be used for supraspinal and spinal anesthesia, respiratory depression, and any like physical dependence. Those are going to be our mu receptors. And then the other one that's more so seen is going to be the kappa receptor. And kappa receptor here is going to be responsible for spinal anesthesia and dysphoria. So, darn it, I wanted to ask you guys this. Okay, so when the opioids act at the opioid receptors, what are they exactly doing? What is the mechanism of action?
Decrease sympathetic transmission.
Yeah, exactly. So, oh shoot. Yeah, so it's modulating specifically. So the opioid binds to the receptor, and then it's going to modulate the synaptic transmission of signals. So it's going to close the calcium channels and decrease that transmission of signal. And so therefore it's going to inhibit release of our catecholamines, acetylcholine, norepinephrine, serotonin, DMA, and substance P. What is substance P again? It represents or is commonly associated with or for
pain.
Pain, yeah. So you can remember it's substance P, P for pain. That's what it's responsible and role is for. So opioids, what are they used for? We're going to use them for all sorts of different things, such as pain, cough suppression, which is specifically, we use dextromethorphan for that, diarrhea. We use the loperamide a lot for those, and diphenoxylate. We can use it for acute pulmonary edema, and then maintenance programs for heroin addicts. So those drugs are going to be our methadone and buprenorphine and naloxone. So adverse effects. What are adverse effects that we see in opioids? If we are inhibiting the release of our acetylcholine, norepinephrine, serotonin.
Constipation, nausea, vomiting.
Yeah, exactly. So nausea, vomiting, pruritus, so itching. There's addiction. Respiratory depression is one of the biggest adverse effects and common cause of death. Meiosis, so pinpoint pupils, that's really a common clue that they give in vignettes. except for meperidine, which causes mydriasis, which is why they also say that meperidine is mostly abused by what occupation?
Doctors.
Yeah, yeah, doctors, because you can't tell that they're on it, I guess. Okay, so tolerance does not develop to meiosis and constipation, and then toxicity is going to be treated with naloxone, which is an opioid receptor antagonist, and then relapse prevention with naltrexone once detoxified, which we're going to talk about as well. So any questions or anything that anybody wants to add here? Okay, so one thing I wanted to go through with us today is like what opioids cause or what we see when there's an intoxication of opioids, and then what we see when there's a withdrawal of opioids. So can anybody tell me what you would see in a patient who is intoxicated with opioids?
Decreased respiration.
Yeah, so definitely decreased respiration, so respiratory and CNS depression. They're going to have euphoria. They're going to have a decreased gag reflex, pupillary constriction, so like we said before, the meiosis or pinpoint pupils, and then they can also be thrown into a seizure. So like I said, it is the most common cause of, I said respiratory depression is a common cause of death, but it's also the most common cause of drug overdose death, and that is caused by respiratory depression. And the treatment is naloxone. So how about withdrawal? What type of symptoms would you see in a patient with opioid withdrawals?
Irritability, sweating, nausea, muscle pain.
Yeah, exactly. So like sweating, dilated pupils, pilar erection, fever, rhinorrhea, stomach cramps, diarrhea or like flu-like symptoms. And here the treatments is what we've talked about. So to get a little bit into that, so like I said earlier, I should have kind of switched it around, but naloxone, the one that's the second drug that you see on the slide, is an antagonist. It is not orally bioavailable, so it's added to lower IV abuse potential. It rapidly will terminate respiratory depression, so it's going to be kind of the first thing that we're going to use in terms of management in a patient who's overdosed, and it rapidly terminates other toxic effects. And naltrexone is our long-acting opioid antagonist, which is used for relapse prevention once we've detoxified a patient. So it's good also to use in patients who also have alcohol dependence, and essentially is the drug of choice for opioid addicts undergoing withdrawal. So that is kind of the overview on opioids. Any questions or concerns? Anyone want to add anything to that?
Yeah, pretty good.
All right. Okay, so moving to the concept. Today I'm going to kind of talk about epithelial tissue. So epithelial tissue is one of the four types of tissues found in the human body, and it has lots of important functions, including protecting the cells found beneath the epithelial layer from things like toxins and acidity. It also serves a role of exchanging nutrients and waste products between the body cavity and underlying cells, and then it also plays a role in synthesis and or secretion of proteolytic enzymes, sweat, mucus, etc. So in general, epithelial tissues are classified by the number of layers and by the shape and function of the cell. So these three general shapes are cuboidal, columnar, and squamous. So cuboidal has cells whose height and width are approximately the same, so it's cube-like. So height and width are in an equal 1-to-1 ratio. The columnar cell has cells that are taller than they are wider, like you see here. So it looks like a column, and it has that column shape, so it's taller than its width. And then the squamous cell is a cell that's wider than their height. So it's wide, flat, and scale-like. So that's going to be our beginning characteristics of these epithelial cells, or cells that essentially make up the epithelial tissue. And then the next concept that we should also hone in on is simple versus stratified. So these epithelial cells, the three that we just talked about, can then be take form of either a simple or stratified epithelium. So simple epithelium is going to be a single layer, and it's usually found where absorption and secretion occurs. The stratified epithelium is multi-layered, and it's found in places that are going to be exposed to mechanical or chemical stress. Okay, so then if we broke down the types of cells that we see in epithelial tissue, we can start with simple cuboidal. So simple cuboidal, like we talked about earlier, so simple is just going to be single layer, and cuboidal is going to be the cube-like. So these cells are usually found in ducts and secretory portions of small glands and kidney tubules. And essentially, it serves the purpose of secreting and absorbing. And this is what it looks like. And then the next type of cell that we can see is simple columnar. So these are found, they're ciliated tissues, like in the bronchi, uterine tubes, and uterus. And then there's smooth, which is going to be non-ciliated tissues that are in the digestive tract and bladder. And essentially, its function is to absorb, and it also secretes mucus and enzymes. So this is our simple, meaning single layer, and columnar. Then our simple squamous are going to be found in air sacs of lungs, the lining vessels and lymphatic vessels, so vessels. And its function is to allow materials to pass by via diffusion and filtration, and it secretes lubricating substances needed, especially like for the air sacs of the lungs. And it's the simple squamous, so single layer, and it's the squamous flat scale-like cells. Okay, now if we're going to move on to the stratified. So we can have stratified cuboidal, squamous, and columnar. So the stratified multi-layer cuboidal are going to be seen in our sweat glands, salivary glands, and mammary glands. And their function essentially is just to be a protective tissue. And you can see here that it's multi-layered, and it's our cuboidal, so the height and width is equal, or in 1-to-1 ratio. Then we have the stratified columnar. So these cells are going to be commonly located in the male urethra and the ducts of some glands, and its aim is to secrete and protect as well. So stratified columnar looks like, which is the multi-layer and columnar cells, so long column-looking cells. And then our stratified squamous, these are going to be located in the lining of the esophagus, the mouth, and the vagina. And its function, again, is to be a protective, to provide protection against abrasion, which are commonly things like from like hot liquids, for example, in the esophagus and mouth. And like you see, it's multi-layered again, and it's the flat scale-like cell. So that kind of sums up the general idea of the simple versus stratified, and then the three general type of cells that you see. However, we also see pseudo-stratified, and these are taller, simple columnar epithelial cells whose nuclei appear at different heights, and because of that different heights, it's under microscope can be confused, and hence why it's called pseudo. So these cells can be ciliated or non-ciliated. The ciliated pseudo-stratified epithelial cells are commonly, or I guess maybe you can call them more high yield or more commonly related, as they are found in the respiratory epithelium and airways like the nose and bronchi, and also in the uterus and fallopian tube. So what's important about these is they're ciliated, and we know that cilia are capable of energy and dependent on pulsatile beating in a certain direction with the interaction of the cytoskeletal microtubules and connecting structural proteins. And because of this role of the cilia and its association with pseudostratified cells, they essentially produce mucus, which is secreted by goblet cells, for example, in the respiratory epithelium. So we can think of ciliated pseudostratified epithelial cells associated with mucus, and hence why it makes sense that they're commonly seen in the respiratory epithelium. So, like I said, again, location is that they're in ciliated tissues that line the trachea and much of the upper respiratory tract. And then its function is to secrete mucus, and the ciliated tissues allow for movement of that mucus. And then the last type of cell that's important to know of the epithelial cells is transitional. So transitional is essentially cells that can change from squamous to cuboidal, depending on the amount of tension on the epithelium. So it's going to be found in tissues, like we know, that stretch. So it can appear to be stratified cuboidal when the tissue is not stretched, but then it will look or appear stratified squamous when the organ is distended and the tissue is stretched. It's also sometimes called the urothelium, since it's almost exclusively found in the bladder, ureters, and urethra. So we always say like smooth muscle is commonly seen in the bladder. So location again lines the bladder, urethra, and ureters, and its function is to allow expansion and stretch. And this is what it looks like. So, like we said, it's going to be nuclei is going to be different heights. Transitional is going to be the cuboidal versus columnar. So, yeah. Did I say that right? I think so. Squamous to cuboidal, sorry. So in the picture, we can see cuboidal, and then I guess these are squamous at the bottom. So yeah, anybody have any questions or want to add anything to that?
Am I right when, since you just said transitional cells normally in the bladder, is that the type of, if you have bladder cancer, is that one that's called transitional cell?
Transitional cell, yeah, I believe so, actually. Transitional cell carcinoma, yeah.
Thank you. Okay.
Yeah, so I guess like you can kind of, right, in a vignette, you can kind of use your context clues of what you know, and if they're talking about a patient who has maybe hematuria, you can consider transitional. cell carcinoma as a differential.
Gotcha. Thank you.
Yeah. Anything else? Okay. So I have a question I have 2 questions for us. Okay. So the first one, a young couple who have been trying to conceive for more than a year come to a fertility clinic. It is determined that the man's sperm, although otherwise completely intact, lack motility. The portion of the testes where sperm normally acquire its motility is lined with what type of epithelium? Columnar epithelium with cilia, pseudostratified columnar epithelium, pseudostratified columnar epithelium with stereocilia, simple cuboidal cell epithelium with luminal flagella, or transitional cell epithelium. So we want to think of sperm and motility as our clues for what type of epithelium is most appropriate
I would
for
get
testes.
cilia, but that's only pseudostratified columnar with stereocilia.
Okay, so you're going with C. Anybody else?
I would agree with that too.
Okay, yeah. So I actually didn't highlight the answer, but yes, the answer is C. Pseudostratified columnar epithelium with stereocilia. So, like we said, the pseudostratified is going to be ciliated tissues, and although I focused on the fact that it lines like trachea, that's not to say that it is the ciliated, so it's found in respiratory epithelium and ureter and fallopian tubes for that fact of what cilia does. However, it's also applicable for in the testes where sperm acquires motility. So if you're thinking cilia, think pseudostratified. All right. Oh, geez. I don't know what happened there. Okay. Okay, so next question. A 10-day-old infant is brought to the emergency department by his parents due to a fever and poor feeding. He has become irritable and fussy over the last 24 hours, which prompted them to check his temperature. At that time, which was 3 hours ago, it was 101.5 degrees Fahrenheit. Current vitals reveal a temperature of 102.7 degrees Fahrenheit. Blood pressure is 106/73 and a heart rate of 163 per minute. On physical exam, he appears lethargic and has more core muscle tone. The infant is immediately given a workup for sepsis and the appropriate resuscitation is started. Results from a CSF analysis are shown, which is, here's the CSF. So we have gram-positive rods, the opening pressure is normal, color is clear, glucose is 34, protein is 90, leukocytes is high, and the culture shows a gram-positive bacilli with tumbling motility form a narrow zone of hemolysis on sheep blood agar. So what is our bug?
Tumbling motility. Listeria?
Right, so we've figured out what the bug is. So now the question is, though, what is the most likely mode of transmission of the pathogen affecting this patient? A, an ascending urinary tract infection. B, direct inoculation into an open wound. C, ingestion of unpasteurized milk. And D, inhalation of aerosolized bacteria.
No.
Yeah. So C, ingestion of unpasteurized milk.
Wait, is she pregnant or?
She has had a child who is, so what does the child have? He has listeria, but what is the manifestation of the listeria?
Meningitis?
Yeah, meningitis. And he's a newborn, and we know that our newborn babies with meningitis are going to, top 3 bugs are?
strep pneumo, Haemophilus.
I
E.
think.
coli, group B strep, and Listeria.
Oh,
Yeah. So baby bell, baby gel. Yeah. Group B strep, E. coli, and Listeria. I've always used that little mnemonic or trick, and it always works for me. Great. So yeah, that's going to be your newborn babies. And then after 6 months is where the H. influenza and the strep pneumo come into play. So yeah, the 6 months mark, because I know I've also then gotten a little confused. But newborns are going to be your baby gel, and then at 6 months, post 6 month mark to like 18 is going to be the next age group for your most likely bugs to infect for meningitis. So yeah, that's all I got. Pretty short and sweet.
So you were showing us the glucose level there.
Yeah. Oh yeah, we can go over that actually.
Is that low? Or
The glucose level, I think, is hold on. It's 34.
Glucose less than 6.
Yeah. I thought I wanted to say it was 40, but maybe you're right, 60.
So everything has, because obviously they're trying to tell us that because it's bacteria, obviously.
Yeah. So yeah. Looking at the analysis, we can see the opening pressure. That's the normal clear.
Almost between 45 and 80.
Okay. 45 and 80. Yeah.
So it is low. So that's just supposed to hint to us that it's bacterial. The bacteria is using it for metabolism. Okay.
Yeah, and then the cell type, neutrophils. So we see neutrophils in bacteria versus in fungal and viral fungal and viral meningitis. You're going to see lymphocytes.
Right.
And then the protein is going to be high or increased for bacteria and fungi, but then in viral, it can be like normal to increased. So, and then glucose is decreased in bacterial and fungal, but then normal in viral.
Sorry, first it's at 40 to 70, but it's between 40 and 80 that I've run across.
So,
Right.
Cool. Yeah, so decrease. So yeah, that's again good stuff to use in analysis. So yeah.
Awesome.